Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. We're so excited to have you joining us today at our event, Children's Health, Improving Equity and Access. This event is related to the release of our October 2020 issue, which was entirely devoted to the topic of children's health. The issue itself wouldn't have been possible without a significant amount of support. You see on the screen here the financial support that we received from a number of organizations, including Nemours, Blue Shield of California Foundation, the Children's Hospital Association, the Episcopal Health Foundation, and the W.K. Kellogg Foundation. I also want to note that all of our theme issues are led by advisors external to health affairs, and I want to thank Christopher Forrest of the Children's Hospital of Philadelphia and Lisa Simpson of Academy Health for serving as theme issue advisors. Now, we've published a number of issues on children's health over the years. It's an issue that never seems to go away. Maybe it's because although children are relatively inexpensive, we seem to perpetually fail to make the investments in meeting children's needs that the evidence says that we should. And so time and again, we have to remind ourselves of the importance of these investments. Maybe it's because our political leaders always tell us that children are the future and children are a priority, and yet year after year we see missed opportunities for our leaders to make the investments that would show that those words really had meaning. But there are maybe more positive reasons to continue to publish in this area as well. In fact, our understanding of children's development and our understanding of interventions that are effective has improved dramatically. And so we want to not just notice the gaps, but to lead the way forward to solutions. And part of why it's important to revisit this topic quite regularly is because as our understanding grows, our ability to think creatively about how to give our children a better future also needs to be advanced. And that's a role that we'd like to play here at Health Affairs. Now, in the old days when we got together, we would convene for half a day at the National Press Club, and you'd be able to hear from all of the authors in the issue. Now that we're in a virtual format, the event is a little bit shorter. The theme that we've chosen for today is a theme that pops out at you when you look at the issue of children's health, and that is the inequities that exist, particularly by race and ethnicity, also by income. We really do live in a country where the opportunity children have is very much tied to their race and ethnicity. And shining a light on that and shining a light on some of the responses to that is the focus of our session today. But I do want to remind you that there are other issues, other papers in this issue that I hope you'll look at as well that won't be presented today. There are a number of papers having to do with behavioral health. And that's an area of course, of great interest and importance for children. There are papers that look at systems of care, oral health, for example, a very interesting paper on combining hospice care with curative care so that children can receive treatment and hospice as well if they have an advanced illness. A number of papers looking at prescription drugs and how much or maybe little we study drugs in children, even though we prescribe to them. And a number of papers also looking at insurance coverage, which we've made great progress on for children, although in recent years we've seen some slippage. That's another topic of interest. So after this event, I hope you'll pick up the issue and look at it in its entirety so that you can see the topics that we've covered in addition to the ones that we're focusing on today. But as I said, today the focus is on equity. After some opening remarks, we'll turn to a panel. Our panelists will present on the papers that they've included in this issue. We'll have a response to those papers and we'll have ample time for discussion. For those of you who are live, I would encourage you to submit any questions that you have. It's just below the screen where you're watching this event. Please, the earlier you submit questions, the easier it is for me to look at them. Don't feel like you have to wait until the very end to put your questions in the queue. So without further ado, I want to turn it over to Debbie Chang, who's the president and CEO of the Blue Shield of California Foundation. She really is a central figure in having brought this issue to life. Not so long ago, she was the Senior Vice President and Chief Policy and Prevention Officer at Nemours Children's Health System. She's had leadership positions in the federal and state governments and was the first federal director of the Children's Health Insurance Program. Debbie has been a colleague of mine for many years, and it's a pleasure to turn the microphone over to you. Debbie?
Great. Well, thank you, Alan. I'm delighted to be here. I first want to thank all the organizations that joined us in supporting this issue focused on children's health, especially my previous employer, Nemours Children's Health System. And I want to thank all the contributing authors as well. Our mission at Blue Shield of California Foundation is to make California the healthiest state and to end domestic violence. We believe that this requires addressing the root causes of poor health and violence and focusing on equity. And so I was extremely pleased to see so many wonderful articles that aligned with these goals. So I want to thank Alan and his team for this very impressive and timely children's health issue. In my few minutes, I'm going to highlight 5 key themes that the authors have focused on that underscore the important lessons that our foundation has also learned. First, we know that in order to prevent poor health and improve health equity, we have to start with root causes. Health outcomes are driven by factors beyond clinical care, including housing, job opportunity, income, and food security. Another important factor that the foundation is working on is to prevent exposure to violence. We know that children who witness violence in the home not only face worse outcomes, health outcomes in particular, but they're also more likely to be perpetrators or victims of abuse as adults. And that's why it's so important to find ways to prevent family violence before it affects children and entire generations. Socioeconomic status also plays a key role. James Fletcher, in his article, notes that children in poor families have worse health, lower birth weight, and more chronic conditions than children in higher income families. He and his colleagues found that disadvantaged groups overall experienced less upward health mobility. And recognizing this need to put more resource and time into the hands of low-income families, our foundation is investing more in what's called the growing care economy. That's the sector that cares for children, people with disabilities, older adults, such as home care and child care workers. In a Health Affairs blog that was just released, I advocate that improving child care workers' job quality and job sustainability leads to better health for children and economic stability for the workers and the families that they serve. And we all know that economic stability is a strong predictor of health. Second, we need to address the social determinants of health with an equity lens, starting first with data and focusing on neighborhoods. And so my good friend Neal Halfon will share his new data showing racial disparities in health and well-being start early in a child's life and have lifelong consequences. I also love that Dolores Acevedo-Garcia and her colleagues highlighted the racial and ethnic inequities in neighborhood conditions in large U.S. cities. And rather than focus on treating disease and modifying individual behaviors, they argue that the health sector should focus on improving neighborhood conditions, and we couldn't agree more. Third, and one of the guiding principles at the foundation is listening to community voices and co-creating solutions. Linda Sprague, Martinez, and her colleagues make the important point that policymakers should actually consider inviting young people to the table to hear their perspectives as they make decisions about healthcare delivery for children. Fourth, as Alan alluded to, we need to maintain focus on areas where we've been successful. Children's health coverage represents both a success story and a warning. And as the first national CHIP director, I was thrilled to see Joan Alker's article pointing to the great strides we've made in terms of reducing the number of uninsured children. But data is showing that we're slipping in this area. And so we must continue to lift up previous successes and ensure that children have access to health care coverage. Finally, identifying what works is only part of the solution. We need to put the findings into action. Jim Perrin's powerful article provides a roadmap for strengthening child and adolescent health and well-being. He outlines the evidence and policies for building family resilience, addressing poverty, preserving healthy communities, transforming healthcare, and supporting collaboration between education and health. So in summary, this issue of health affairs offers an important path forward. At the foundation, we're striving to achieve bold and aspirational goals, including envisioning a world of thriving communities and without violence. And I urge us all to envision a world of healthy and thriving children. We can't lose sight of what's possible, but we know it requires concerted effort and strong leadership. We need a dedicated position, either situated at the White House in the next administration, or a cabinet level position charged with advancing the goals that have been laid out in this health affairs children's issue. A true champion for children and supportive policy changes are needed to prioritize the health and well-being of children. I look forward to working together to ensure all children grow up healthy and supported. And again, I want to thank everyone for their contribution to this wonderful issue. Thank you, Alan. I'll turn it back to you.
Thank you so much, Debbie, for your leadership in making this issue happen, your leadership on issues around children in general, and for those great introductory remarks. I'm going to introduce the speakers who have papers in the issue. You're going to hear from Jim Perrin, professor of pediatrics at Harvard Medical School and former director of the Division of General Pediatrics at the Massachusetts General Hospital for Children. You'll hear from Linda Sprague Martinez, associate professor and chair of the macro department at the Boston University School of Social Work. You'll hear from Dolores Acevedo-Garcia, Samuel F. and Rose B. Gingold Professor of Human Development and Social Policy, and Director of the Institute for Child, Youth, and Family Policy at Brandeis University. Neal Halfon, Founding Director of the UCLA Center for Healthier Children, Families, and Communities, and Director of the Child and Family Health Leadership and Training Program in the UCLA Fielding School of Public Health. And Katie Jajtner, Assistant Scientist and Postdoctoral Trainee at the Center for Demography and Aging at the University of Wisconsin-Madison. Each of these presenters, as I say, has a paper in the issue. We'll just go through those in order, and we'll start with Jim Perrin. Jim, to you.
Thanks so much, Alan. And Debbie, you've really set a great stage for where we're going to go. Our work in this particular paper has been based on 3 or 4 major principles. One is that much recent research shows how early life experiences and adversity change brain and child development, and shows also the importance of and critical roles of parents and other caregivers. That U.S. children and youth have, any way you measure it, much worse health than our counterparts in other industrialized countries, and especially among Black, Latinx, and Indigenous people communities. So higher infant and child mortality, poverty, hunger, obesity, death from gun violence, incarceration, school failure, and very impressively, early mortality, higher rates of mortality, believe it or not, beginning at age 15. So we don't have a healthy population of young people, and the inequities within that lack of health are really quite dramatic. Third, high rates of early adversity worsen the long-term health and wellness of adults, and these two have been very much exacerbated with the COVID pandemic. And fourth, Alan said this a moment ago, good and strong evidence shows that several public programs have substantial benefit to young people and families. Things like the expansion of food stamps, the earned income tax credit, public health insurance, very, very good evidence that these really do work. If I can have the next slide, please. Our paper is based on 4 reports from the National Academies of Sciences published last year. And we've tried to work together to synthesize these reports because they actually, even though they addressed the problem from very different lenses, they came up with some common priorities and strategies. One is a roadmap to reducing child poverty. And I'll just briefly say, Dolores is a member of this committee. that this committee estimated the annual costs of U.S. child poverty are between $800 billion and $1.1 trillion per year. They also looked at what would work, and they came up with two packages of several programs that would achieve the goal of reducing poverty by half in 10 years, both including expansions of the EITC and the Child and Dependent Care Tax Credit. One then expands nutrition programs as health and housing vouchers. The other works more on child support assistance, an increase in minimum wage, and elimination of immigrant eligibility restrictions for legal immigrants. These programs in the aggregate, if either of these packages were put into place, would cost on the magnitude of about $100 million per year, much less than the cost of child poverty to our economy. The next one is called Fostering Mental, Emotional, and Behavioral Health in Children and Youth. And in this one, the recommendations include developing comprehensive multifactorial interventions to foster mental and behavioral health, including integration of mental and emotional and behavioral health into the rest of healthcare. It does discuss a variety of individual and family and community interventions and calls for a decade of the child, bringing together multiple sectors to work in this area. The third report is called The Promise of Adolescence, and really addresses some of the issues about listening to adolescent voices that we'll hear more about shortly, but also documents that neuroplasticity, the changeability of the brain, offers major opportunities for growth and repair in adolescence. And this report does talk a great deal about the importance of involving youth in the development and organization of programs. It also talks about investing in families and community, and reducing disparities and inequities. The fourth report is called Vibrant and Healthy Kids, based on others on the growing database and growing science, and it provides recommendations in four main areas: income support, much like the first report; parent and family support with stable living conditions, and I'll talk more about that at the end of my few minutes. Third is transforming healthcare to be family-centered, to integrate mental and behavioral health, to have screening intervention for social drivers, and to develop team care to support care. And finally, areas in early childhood education. Next slide, please. So in our roadmap, which is in the paper, we provide first some principles that we talk about children first, the engagement of all parts of society to support the development of children's issues. Third is recognizing the power of prevention. Fourth is developing life course approach and equity across the life course. And fifth is recognizing that doing what we need to do will take some work to implement it effectively across sectors. Priorities among these four reports are to focus on young families, to have a real focus on poverty reduction, to work on cross-sector collaboration, to do innovative financing, and have a coordinated national agenda. Next slide, please. So the policies then that we're recommending here are, again, income support. I mentioned most of these, but expand earned income tax credit, child and dependent care tax credit, convert the existing child tax credit into a monthly child analysis, reduce income inequality and discrimination, building family resiliency, implementing paid family leave nationally, expand community programs to help families with child care and development, improve housing assistance, expand nutrition programs, programs that we know work, but cover well less than half of the potentially eligible households in America. Third, for healthy communities, there are aspects of harm reduction, such as exposures to toxins and tobacco, and really climate change kinds of issues are critical here. Fourth is transforming healthcare, as I mentioned, expand team care, integrate healthcare with other community services, expand coverage. We've made real progress, but we have some progress still to do, and payment reform to incentivize the right sorts of things. The next one is supporting collaboration between education and health. Pretty obviously we need to do that. The next is cross-sector goals and collaboration. And the last is really addressing equity, recognizing how important inequities have been in leading to the poor health of many, many young and now older Americans as we develop these programs. Thank you very much.
Thank you, Jim. That's a great overview of what we know about what works and what we should be doing. I'll turn it now to Linda Sprague Martinez. Linda?
Great. Thank you so much, Alan. And thank you, Debbie, for providing that framing at the beginning. It was so helpful. Good afternoon, and thanks for allowing me to share our team's work today. Our paper really highlights the benefits of youth participation. Youth participation is the process through which young people become engaged in and influence the issues in institutions that directly impact their lives. Participation has been found to promote resilience, wellness, and prevention. And more importantly, engaging with young people as partners, as collaborators, leaders, and decision makers can help to ensure that public health and health systems efforts are well aligned with the priorities of young people and really meeting their needs. There are also, in the context of equity, been many examples in which youth participation can help elevate the voices of marginalized young people and low-income populations. And so you can click to the next slide. And here I have a quote from Paulo Freire. And Paulo Freire, he speaks to how Western educational approaches inhibit our ability to really harness the expertise of young people. In what he calls this banking system of education, in which that assumes that we as adults are experts, and that experts and knowledge lie with us, and that it's our job to really fill learners with knowledge. And what that does is that model, it fails to recognize the lived experience that young people bring to the table. And so when we approach our work, participatory action research, we're really thinking about how can we decolonize knowledge production to recognize the assets, the strengths, and the nuanced understanding of the built environment and living conditions that young people have, how that can inform our work. So we engage with young people by hiring them. As university researchers, we sometimes have to work with community partners to hire young people, and we really work so that they can help us to understand the concerns and priorities that they're seeing in communities. And we as researchers are providing some scaffolding, some training. And in partnership, we work to kind of think about, well, what are the methods that best help to understand young people to explore the priorities that they have and the research questions that they have. And so on the next slide, I shared with you a few of the concerns that we heard from young people in their communities. And these are consistent. This project that we report on in Boston is consistent with a number of other studies we've done with young people across the country and with other groups in Boston, where we're hearing about things like food security as a priority for young people. We're hearing about mental health as a priority for young people, sexual health as a priority for young people. And we're hearing about how those health issues intersect with structural racism, with racial profiling, how those factors begin to impact food access, how that plays out as young people are navigating the food environment, how they're treated and profiled when they enter buildings, how they're policed. We hear about mental health access from young people in terms of how mental health services look different in different communities, and what resources young people have access to look different in different communities. And one of the interesting things that we find time and time again are that young people are fully aware of the inequities that exist. They don't have the same language. They don't talk about those inequities the same way we do, but they are very aware of it. And one thing that we also see happening is it's very easy for young people to internalize their environment and think that things look the way they look because they are who they are, because we don't teach about this broader history of why the social determinants matter so much, and why things look different in different communities, and the ways in which ideologies of white supremacy culture or racism have kind of trickled down into policies. We don't teach that. Unless you're an American Studies major, unless you're a social work student later, you might not be exposed to that understanding of why it is that there are unintended consequences of social policies that are leading to these differential conditions. And so through those dialogues with young people, we're able to really begin to develop a holistic understanding of health and well-being. You can click to the next slide. And so we present youth engagement. We believe that it has tremendous opportunity to enhance healthcare delivery and that there are so many opportunities right now with a focus on whether it's patient family advisory boards in hospitals and healthcare systems, patient boards, whether it's through school community partnerships for health. There are many opportunities to engage young people as stakeholders and in leadership roles within healthcare systems and within public health. But we also see that there's always a risk or a threat in the power and positionality that we as adults play as gatekeepers to those opportunities. And so we've been, the young people that we work with and the study we report on, some of them are now involved with the board at the hospital. And they're building kind of together. We've been working with adults and with young people on how do we really create space for young people to lead, because it looks different than when we as adults are leading. We've also encountered some institutional barriers, whether it's health and human resources policies around hiring. You know, what does it mean to hire a 14-year-old? What do you need to have to be hired as a 14 or a 15-year-old? Well, we need an ID. Well, who has an ID? What schools offer IDs? What schools don't? So really, I don't want to get into the weeds too much, but there are important considerations for adults to take into account as we begin to engage with young people and begin to create partnerships where we're developing reciprocal relationships with young people. So I'll stop there. Thank you.
Thank you, Linda, so much for introducing those concepts. And we'll now turn to Dolores Acevedo-Garcia. Dolores.
Thank you, Alan. Our paper examines racial and ethnic inequities in children's neighborhoods. Sadly, the relevance of this analysis is even higher today as we grapple with the stark geographic and racial inequities that COVID-19 has exposed and exacerbated, and as we grapple with a long overdue reckoning with our history of institutional racism. Next slide, please. Neighborhoods matter for children, not only because they influence the quality of the experiences that children have today, but also because they influence their health, physical and mental health, and education during childhood, as well as their health and socioeconomic outcomes as adults. So we developed the Child Opportunity Index 2.0 to create an aggregate measure of factors that are important for healthy child development. That includes factors such as availability of early childhood education, academic outcomes in neighborhood schools, availability of green space, and walkability, and healthy food. Next slide, please. We combine all these indicators into a single measure that we call the Child Opportunity Index. And then we rank all the neighborhoods in the US, that's about 72,000 neighborhoods, into a score. Score ranges from 1, which is the neighborhoods with the lowest opportunity in the entire country, to 100, which is the neighborhoods with the highest opportunity in the entire country. I'm going to talk about some of the findings, and I'm going to use a lot of numbers. However, as I discuss the findings, I want you to please keep in mind that the numbers or scores are a reflection of the actual conditions that our children are experiencing today in their neighborhoods. First, we measure overall opportunity in the metropolitan area by summarizing the neighborhood opportunity scores of all its neighborhoods. So that provides an overall measure. Not all metros are the same. Some have higher overall opportunity than others. For example, El Paso has low overall opportunity with a score of 35. Chicago has medium overall opportunity with a score of 57. And Boston has high overall opportunity with a score of 78. Although there are inequities across the country between metros, one of the most important findings is that most of the variation or inequity in child neighborhood opportunity happens within metros. Next slide, please. We see vast inequities in child neighborhood opportunity within metropolitan areas, often in a single metro, just a few miles apart, Some children experience the very best conditions available to children in their neighborhoods across the entire country, and some children experience the worst conditions. Not all metros are the same though. Some metros are more unequal than others. We measure the extent of inequity within a metro using what we call the child opportunity gap, which is the difference within a given metro between the opportunity scores of its very high opportunity neighborhoods and the scores of its very low opportunity neighborhoods. In some metros, this child opportunity gap is very large, very large. What we mean by that is that the gap between its highest and lowest opportunity neighborhoods is at least as large as the gap between lowest and highest opportunity neighborhoods that we see across the entire country. In terms of our scores, that is a gap of 80 points or higher. We call these metros with very large child opportunity gaps hoarding metros. These metros are characterized by extremes. In these metros, some children live in neighborhoods of concentrated opportunity or affluence, and other children live in neighborhoods that have long suffered disinvestment and neglect, and as a consequence, have a pattern of concentrated disadvantage or very low opportunity. As an example, let's focus on Detroit and Colorado Springs. These two areas overall have similar opportunity. Their scores are 54 and 56 respectively. However, in Detroit, which is a hoarding metro, the child opportunity gap is much larger than in Colorado Springs. In Detroit, the gap is 93 points compared to 64 points in Colorado Springs. Or for very low opportunity neighborhoods in Detroit is only 2. So children in Detroit in very low opportunity neighborhoods within this metro experience some of the toughest conditions that a child can experience across the entire country. In contrast, in Colorado Springs, the score for very low opportunity neighborhoods is 24. Still relatively low opportunity, but considerably better than similar neighborhoods in Detroit. Next slide, please. Key finding and theme for our paper and our work is that opportunity hoarding is not race neutral. Not race neutral. Opportunity hoarding hurts all children that live in the lowest opportunity neighborhoods, but it disproportionately hurts Black and Hispanic children. First, in hoarding metros, Black and Hispanic children live in neighborhoods with much lower opportunity than white children. And second, while there are racial and ethnic inequities in neighborhood opportunity in practically all metros, these gaps or inequities are much higher in hoarding metros. As shown on this slide, if we focus, for example, on hoarding metros with high overall opportunity, metros like San Francisco, like Boston, the gap between the opportunity scores for Black and white children is 58 points. The typical Black child in these hoarding metros lives in a neighborhood with a score of only 20, while the typical white child lives in a neighborhood with a score of 78. If we now turn to sharing metros with high overall opportunity, there's still a gap, a racial gap between Black and white children, but the gap is 32 instead of 58 points. The main difference is that for Black children, in hoarding metros, Black children live in neighborhoods with a score of only 20. In sharing metros, they live in neighborhoods with a score of 47. Next slide, please. I want to invite you to please go to our website, diversitykids.org, to get more data and information about our Child Opportunity Index. One of the most important and exciting aspects of our work is that many people and organizations are using our data to improve conditions for children. We would love for you to consider using our data. Please reach out. Thank you.
Thank you so much, Dolores. Before I turn to our next speaker, just remind those of you in the audience that if you want to submit questions, you can do so below the video and the screen. We'll have time for those later, but now I'm happy to turn to Neal Halfon. Neal.
Thanks, Alan. I really appreciate the opportunity to share our work and also the hard work of all the communities we've been working with over the last several years that really are committed to trying to improve the well-being of children in their communities. First slide, or next slide, please. Our paper focuses on the health equity gap that exists early in life. And health equity is a growing concern because the rates are rising. And what we know is that equity gaps begin early in life. And what we also know is that differences in children's health and development have a tendency to compound over time, so that little differences in little children oftentimes become big differences in adults. And as Dolores has clearly shown, is that threats to equity are not evenly distributed. And more, as Jim was pointing out, we understand the life course implications of inequities, both in terms of the school success of children and the health problems that they will have, but also in terms of the developmental origins of what are called adult health conditions, so that many adult health conditions have their origins in these inequities early in life. And at present, we ignore those at great peril, cost, and risk to ourselves. Next slide. What we did is we used something called the EDI. The EDI is the Early Development Instrument. It's developed in Canada. It's a measure of children's health development and well-being in 5 domains: physical health, social competence, emotional maturity, language, cognition, and general knowledge. You can think of it as a health-related quality of life of a 5-year-old. And it's been used in across Canada and all of Australia and about 10 other countries. And it's become a really important measure of health development and well-being. And it's especially important in communities because you're able to measure things across an entire city or across neighborhoods. And even though we've highlighted how important the early years are in terms of long-term development and health of children, at present, in most communities, the only measures that they have of children's health development and well-being are birth measures that take place that are collected at birth, and then measures of 3rd grade reading, so that between birth and age 8, children are largely invisible, even though we say that that is one of the most important times of development. In this study, we used data from 98 participating school districts in 8 states that we collected over a 10-year period of time. What we did is we looked at aggregate measures of the vulnerability in one or more of the domains listed here by neighborhood median income, according to race and ethnicity. And we did a variety of different statistical tests to sort of adjust for clustering and linking. Next slide. What we found was that there were big differences in vulnerability by income. That's not a big surprise, but there were significant racial and ethnic differences over and above the income differences. And that Black and Latino children have the highest levels of vulnerability overall when not accounting for their neighborhood conditions. White children who live in the poorest neighborhoods are actually the most vulnerable, and white children have the biggest or steepest gradient. And the data suggests that also that some ethnic populations, specifically Asians and Latinx kids, are resilient to some of the effects of poverty when compared with their peers. Importantly, what it also shows is that the EDI can measure children's health equity gaps and inform the design and implementation and performance of the kinds of multi-sector place-based initiatives that Jim was talking about as being necessary as we move forward. Next slide. In this slide, you see on the left, actually, in both left and right, you're seeing the same data, and it's just presented in different way and visualized in different way so that it can be used in different ways to create different narratives. On the left, what you see are the levels of vulnerability as high as 35% of children being vulnerable in the lowest income neighborhoods, dropping down to about 17% in the highest quintile neighborhoods. And what you see is in the blue, the white children, then the orangey red one, the African American children, the gray is the Asian children. What's important to note here is that the highest income African American children are doing worse than the lowest income Asian children. And you see that how big the gap is, not only for those living in poor neighborhoods, but also in the higher income neighborhoods. On the right, what you're seeing is the same data, but actually looking at it in terms of a equity gap. And what you're seeing in the orange is that all of the African American children have higher rates of vulnerability when compared to all of the other race and ethnic groups. And interestingly, the highest income African American kids have even the biggest gap, equity gap, than the lowest. The next, you see that all the Asian kids actually are doing better than in all income groups. You see the Hispanic kids have a gradient so that those in the lowest income actually are doing better relative to those in the highest income, and you see actually exactly the reverse gradient for the white kids. Next slide. So what we've found is really evidence that really suggests we really need to chart a new way forward, as Jim was laying out. The U.S. suffers from significant, persistent, and highly racialized health inequities rooted in complex historical, social, and structural factors, as the other authors have also highlighted. And this is particularly at the nexus of race and income. Eliminating these inequities would drastically reduce healthcare costs, increase productivity, diminish preventable human suffering, and begin to remedy the consequences of centuries of unremitting and unresolved racial injustice. And there's a real need to reduce inequities that's been really highlighted by the COVID epidemic in terms of how the pandemic has really revealed how pre-existing racialized health vulnerabilities is resulting in really devastating outcomes for people of color throughout the U.S. Thank you.
Thank you so much, Neal. And our final paper presentation will be from Katie. Katie, over to you.
Thank you to Health Affairs for organizing this panel and for the opportunity to share our research. My name is Katie Jajtner. I'm a researcher at the Center for Demography of Health and Aging at the University of Wisconsin-Madison, and this is joint work with Jason Fletcher, who is also at the same center. Today, I'm going to briefly summarize our findings examining the childhood origins of intergenerational health mobility as a unique lens into health disparities among children. Next slide, please. Intergenerational health mobility measures the extent to which children's health either mirrors or contrasts with their parents' health. We think of it as a measure of equality of opportunity in terms of health for children. So in a sense, if there's health equity, then children's health should be independent of their parents' health. From previous research, though, we know that health is persistent across generations. Researchers have identified that parents and children are similar in terms of low birth weight, specific health conditions like asthma, hay fever, and chronic migraines, and even general health status. We also know that parent socioeconomic status and income are strong predictors of child health. Put simply, if parent income appears protective against poor health in childhood. Kids from lower socioeconomic circumstances can be exposed to more health shocks, and in the US, they may be less likely to fully recover. Previous research has also highlighted the possible role of local communities in determining child health. For example, different states have the opportunity to enact different safety net policies like Medicaid, which may improve child health. For a more localized example, we can also think about how the Flint water crisis helped shape child health disparities at a very local level. With this as our reference point, we set out to determine whether health mobility that previous studies have identified in adulthood is already apparent in childhood. We then examined what individual characteristics help predict high or low health mobility, and finally, we analyzed the role of community characteristics. There are a number of ways to measure intergenerational health mobility. For the purposes of this study, we used absolute mobility, meaning the predicted health for children conditional on their parents' health. Here, we're going to focus on upward health mobility specifically, which means that we're reporting average health for children conditional on their parents' health being at the 25th percentile. Next slide, please. We find stark variation in intergenerational health mobility by early childhood. We'll first take a look at individual upward health mobility in Exhibit 1 from our paper. The mobility reference point, which is the dashed red vertical line, is a reminder that we're looking at the average health rank for kids whose parents are at the 25th health percentile, regardless of demographic characteristics. So we can look at health mobility disparities by race ethnicity as an example. Non-Hispanic white kids whose parents are at the 25th percentile of health, on average have health around the 45th percentile. Put another way, they have 20 percentiles of upward health mobility. Non-Hispanic Black kids or Hispanic kids, though, whose parents have similar health, only experience 11 to 13 percentiles better health than their parents. Kids without health insurance have 6 percentiles less upward health mobility relative to kids with health insurance. If we look at differences by parent education, we can see remarkable disparities in health mobility. Kids whose parents have attended 4 or more years of college have more than 20 percentiles of upward mobility, while kids whose parents lack a high school credential have only 6 percentiles of upward mobility. Next slide, please. Exhibit 3 from our paper highlights upward mobility results at the community level. First, we did not find much variation in health mobility for urban versus rural areas. Our sample of kids are actually clustered into 820 schools across the United States. So we broke the sample up into roughly equal thirds of school characteristics that are reflective of the community. A key consideration here, though, is needing to disentangle individual and community characteristics. So we account for similar individuals potentially sorting into communities by estimating community results net of individual characteristics. For example, communities with the highest portion of married parents are identified by schools where more than 83% of children have married parents, whereas communities with the lowest portion of married parents have fewer than 65% of kids with married parents. These areas have about 5 percentiles less upward health mobility relative to communities with the most married parents, regardless of whether an individual's child's parents are married or not. Similarly, communities where less than 90% of children have health insurance also have 5 percentiles less upward health mobility relative to communities with full insurance, regardless of the child's health insurance status. A key caveat to our study is that it is descriptive and does not identify causal processes. So we can think about different explanations, but not really adjudicate between them. If we keep with the health insurance example, one hypothesis could be that these communities have lower prevalence of communicable disease because most kids are insured, or perhaps there are more healthcare providers available in the community. An alternative and equally valid explanation might be that the communities with low health insurance simply capture a broader measure of socioeconomic disadvantage. We conclude that there is a lot of variation in health mobility in the United States. People in places that are characterized by disadvantage on average have less upward health mobility and more downward health mobility. These patterns are evident by early childhood, and we suggest health mobility is one way of looking at the quality of opportunity in health. Thank you.
Great. Thank you for all of those presentations. I do want to make sure those in the audience know that this event is being recorded, and once we've produced it along with the slides, it will be available on our website. So if you're looking for slides, just come back in a couple of days when the video is posted. So you've heard a lot of great data and analysis. It's now my pleasure to introduce our speaker, who will provide a little bit of real-world context for this discussion. Mayra Alvarez is the president of the Children's Partnership, a nonprofit children's advocacy organization based in California. She came to the Children's Partnership from the U.S. Department of Health and Human Services in a number of positions, including most recently as director of the State Exchange Group in CISIO, the Center for Consumer Information and Insurance Oversight. She was a David Winston Health Policy Fellow in the Office of Senator Barack Obama. She offers perspective on the data, but also experience at federal and state levels working on these issues. It's really a pleasure to have you with us. Mayra, I'll turn it over to you now.
Thank you, Alan, Debbie, and the team that coordinated this important event today for the invitation to join you. And thank you to our previous presenters for their incredible work and sharing vital information about the status of child health in our country today. I am truly honored for this opportunity to be with you today. As the audience may or may not have noted, I'm not a doctoral level researcher. I am an advocate. I've had the honor to serve in the Obama administration and for amazing public servants. So I have some policy chops, but whether within the federal government or now at a not-for-profit, I've always been an advocate for families like the one I grew up in and millions of others across the country. I am the proud daughter of Mexican immigrants. I grew up in a working class household where no matter how hard my parents worked, they never owned a house, never invested in a 401k, and health insurance coverage was rare. But culture, love, and a deeply rooted sense of community was a part of our medicine. Today, in my role as a child advocate, I hold these values close to heart and close to the work we need to do in order to see today's research translated into action, into meaningful policy change, and no time is more critical than now. So in the few minutes we have together, I have 3 quick messages about what we've learned and how we move forward. 3 Ds: disrupt, defer, and demand. So the first is to disrupt. As each of these articles referenced and our speakers reinforced, racism is real and it's damaging. And it's always played a central role in the publicly funded systems that many families rely on or should be able to rely on to help raise their children. In moving forward, we must find ways to disrupt oppressive systems and old ways of thinking in order to better serve children. Today, Americans are facing a confluence of crises: COVID-19, a challenging economy, and a national reckoning on racial injustice. But it is Latinx, Black, and immigrant families that continue to bear the brunt of these crises and its devastating consequences, while simultaneously shouldering the frontline work that's kept our country's economy running. And it's across the board families of color with children that are being hit hardest. Included in multiple articles and reinforced by the experiences of millions of people struggling across the country today to support child well-being, we know we need a robust safety net, Medicaid expansion, investments in public education, increased support for nutrition programs like SNAP and WIC. We need an expansion of universal supports for Americans, healthcare, income, and as we've experienced so clearly during this pandemic, the internet, all critical components of a family's ability to raise healthy children. Yet, in providing that safety net, as the great Dr. Rhea Boyd says, we must move to abolish racism from every institution, every policy, and every social norm in which it operates and too often hides. Recognizing that disguises like work requirements or family caps or drug testing or patient mistrust, these are disguises that are fundamentally rooted in oppression and control of the lives of people of color and their children. And these disguises are holding children back. So it's not enough to highlight racial disparities. The time is now for us to step back and question the underlying assumptions shaping the systems that perpetuate such inequities and the policies they implement. So out of this moment, I hope we come out wiser, more reflective, and more united in our will to disrupt systemic racism and double down on our commitment to the health and opportunity of every child. And that starts with knowing that we cannot do right by all children in this country until we do right by Black children. immigrant children, and other children of color. My second message is to defer. Defer to the knowledge, expertise, and power of communities, including young people. As researchers, advocates, and as community members, it's our responsibility to reflect on what's been happening in our country, but to also actively work against long-standing racial inequalities that are seeped in our programs, our policies, our communities, but that rob children of the opportunities, services, and supports they need to live healthy and thrive. A part of this is to challenge the system or systems that brought us to this point, and a recognition that these systems, our health, early childhood, education, judicial systems, and more, were not set up to support children, and in particular, children of color. Communities themselves have implemented solutions. No child care center that's affordable, families and friends step in to support. Cars broken down and there isn't enough money for bus fare, will carpool or walk with you. Confused and scared by the lump in your breast or your child's headaches, let me accompany you to the doctor and help you understand your next steps so you're not navigating this behemoth of a system alone. Out of necessity, communities created networks of care. They trained community health workers and they integrated care into the community because the traditional healthcare system was not meeting their needs, or worse, mistreating them. Throughout the journal, there are multiple examples of how we can deliver on what communities have been doing for centuries, where community-based doulas are educating, connecting families with the care they need to stay healthy, where young people are giving voice to the supports and services they need in their community and are validated, where neighborhoods and community hubs are serving as resource centers for health information. There is plenty of evidence of policies and structures that can make a difference for children, and in doing so, not reinforce social hierarchies. Programs that are challenging the status quo and bringing that care where children are, initiatives that refuse to allow care to be transactional and recognize kids are part of families and families are part of communities, and finally, a validation of the brilliance of community leaders, recognizing that those closest to the problem are closest to the solution, as the quote goes. My final D is to demand. Demand better for our kids, for our communities, and for our country. I've been told more than once that I'm an eternal optimist. One of my strengths, literally one of my strengths according to StrengthsFinder, is positivity. However, I recognize and appreciate that many of you've been at this for some time, longer than I have. And for others, you may reside in states where prioritizing children may not be at the top of the list. But if there's anything I took away from our presenters in the journal, it's that change is possible. We have decades of research that document positive outcomes. We know what works. The fact that we're having this conversation around child health equity is progress. Working together, we can muster the political will necessary to prioritize our children and young people. The last 6 months have demonstrated that a return to the status quo is not acceptable. I believe it's why all of us are here today or watching from home. It's for our kids. It's for the one probably on Zoom in the room next to you. It's for your grandkids. It's for the child I hope my husband and I will have one day. And while we are all here today, there continue to be messages of divisiveness or negativity, either in the back of your mind, disappointed by past missed opportunities, or right in front of you, disheartened by comments by elected officials. Well, let's remember, around the world and on both sides of the political aisle, the safety of children is generally upheld as a universal value. With good reason, it's understood that children deserve special status and need to be protected and taken care of, not only by their parents, but by all of us in society. It seems that there are efforts to move us away from those values in an effort to focus on self-reliance, the idea that parents are responsible for their own children, rather than children being the responsibility of all of us, as a family unit, a community, a state, and a nation. We can get this done because moving forward for kids is not an isolated request. It doesn't belong to pediatricians or child advocates or public health researchers. It is all of ours. When you listen to the calls to action chanted in the streets for months over the summer, they were calls for justice. Demonstrations of thousands in cities and communities across the nation that reflect the pain of hundreds of years of systemic racism, state-sanctioned violence, trauma, and inequities endured by Black communities and communities of color and carried by children. Carried every day in the health status of Black children, children of color, and all children. So in closing, over 15 years ago, a relatively unknown state senator, and a few years later, my first boss on Capitol Hill, asked the American public, do we participate in a politics of cynicism or a politics of hope? As we count down to the election, 13 days, in case you're wondering, we have the opportunity to elect leaders that stay true to the universal value that children are our priority. Elected officials that will seize this moment to write the course for children across the country. It's the story our country can be proud of, just as the New Deal was born from the Great Depression, or WIC was created in response to women and children's malnutrition, or public health best practices in response to a previous pandemic. We're in need of a new way forward that disrupts oppressive systems, defers to community leadership, and demands bold innovations that put the well-being of our children first. Children are incredible. We know from decades of research on brain science that adversity can be overcome and resilience thrives in the many of us that may not have had the ideal circumstances for growing up healthy. Aziz Hardiman, a young Black man from North Philadelphia who grew up in a low-income family and grew up to become a Rhodes Scholar, said it best. Don't be happy for me that I overcame these barriers. Be mad as hell that they exist in the first place. This is a moment to not go back to business as usual, because going back is accepting the status quo that left far too many children behind. It's a moment to seize and to bring about real change for Black and brown children, for all families and communities. And in doing so, begin to pave a better way forward for all children in our country. I look forward to working with each of you to make it happen. Thank you.
Thank you so much, Mayra, and for bringing us back to the issues families face every day and that you're working on every day, drawing out the evidence that's been presented here. That was really a great way to transition us into a conversation. The question floor is still open. I have a number of them, and I'll start going to them in a moment. I just will run through a few that are a little specific that people have sent in and then maybe broaden out. But let's go ahead and bring everyone into the conversation at this point. I'm going to start with the first question that came in that was about mental health. It was noting that there's tremendous unmet mental health needs, particularly for children and adolescents. And there was a question about how to address the health workforce shortage for children, especially in psychiatry. I'm going to take this as a somewhat broader question, asking those of you who are conducting the research where mental health fit into some of the metrics that you are looking at. And certainly if any of you have suggestions that directly address the question about workforce, would encourage you to respond to those as well. Remember, you're all on mute, so don't forget to come off when you speak. But does anyone want to start this discussion? Jim, go ahead.
Well, Alan, I mean, our report doesn't really address the workforce issue, but it certainly addresses the critical nature of reintegration of mental health into the rest of healthcare as an important part. And, you know, there's a real tendency in healthcare in general, but certainly in mental health care, to really focus on the kids with really serious emotional, behavioral issues. But the reality is, there's a ton of work we can do upstream, should be doing upstream in the area of prevention, early identification, supporting young families, and so forth. So I think I really framed the question about how do we sort of get this back together again, recognize how tremendously important mental health issues are for kids, and think about the best upstream strategies for changing that. Workforce, big issue, but I'd also stress that many people can help to play a role in the mental health improvement area. So we talk about team care and the involvement of community health workers in team care. And we know from families, community health workers can play a huge role, for example, in the early identification and really management of some mental health conditions.
Alan, can I chime in on that? Neal.
Sure, Neal. Go ahead.
What we know also, if we look at trends in children's mental health, is that the number of kids with mental health problems is really increasing really rapidly. It's one of the syndemics that's going on now with obesity, mental health problems, neurodevelopmental problems, and addiction disorders in kids are all skyrocketing. And they all start early. One of the issues with the EDI, the measure that I was talking about, is that it really is heavily weighted towards social emotional development and giving that data to communities, to neighborhoods, so that they can have it and use it to plot their own course. And the mental health workforce in communities isn't just psychiatrists and child psychologists, but it's promotoras and all the informal networks that actually support families in trying times. So we really need to broaden our view of what mental health prevention looks like. And it's really about sort of the well-being of children. The more we promote the well-being of children, the more we inoculate children from mental health problems as they get older.
Linda, please go ahead.
It's funny, one of the main areas that young people we work with on research teams, they want to focus on as they begin to prioritize around health is mental health. And they talk about it in different ways. They talk about it in stress, they talk about it in well-being, they talk about having access to an adult who they can talk to about their feelings and not having that always. And so, I will say that they have adults within their families that they talk to about their feelings, but sometimes it's also helpful to have an outsider perspective, and because they'll often discuss kind of having to, they live in sometimes two different worlds, where the world of their family, the world of their school, and so access to mental health services is something that comes up consistently. There's, not they don't always have access to mental health services within the school context. Some young people are, if you're disconnected from school, you don't have access to services, but barriers to mental health services are one of the key things that we hear about across cities where we work with young people. And so in terms of thinking about how the mental health workforce, I think, is an important piece. And one of the things I was recently doing our TV news station, we were doing a talk about this piece, myself and one of the youth co-authors who's a senior in high school. And when we started working together, he was a sophomore in high school. And one of the things he said to the reporter, which I saw after because we were interviewed separately, is that, through that project of being part of youth adult partnerships, being involved in his local healthcare institution, he learned about all these different areas of health and areas. He learned about public health, he learned about providers, but how do we actually, thinking about workforce development and thinking about pipeline programs is how to expose young people early on to different types of health careers and who has access to those opportunities. It's not always young people of color. It's not always low-income young people. And so how do we, I think, create opportunities for young people of color, Black and brown young people, to be involved in our systems early so that they're gaining that same exposure to the different types of career opportunities, I think is an important consideration.
Dolores, and then I'm going to bring in another question. Go ahead, Dolores.
Yeah, so just quickly, I wanted to bring us back to the issue of structural factors. So Jim mentioned that I was part of a committee that examined how we can reduce child poverty, and we've been talking about inequities. Black and Latino children are much more likely to live in poor families. About 8% of white children live in poor families compared to about 18% of Black children, 22% of Hispanic children. So we have already much higher risk in terms of family poverty among Black and Hispanic children, and that is connected to all kinds of health issues, including mental health, although in our work we do not measure effects on mental health. And then if you think about multiple layers of risk, poor children of minority backgrounds, so Black and Hispanic children that live in poor families are much more likely to simultaneously live in very low opportunity neighborhoods than their white counterparts. So 66% of Black children who live in poor families live in a very low opportunity neighborhood. Half of Hispanic children in poor families live in a very low opportunity neighborhood. 20% of white children who are poor or live in poor families live in a low opportunity neighborhood. So the issue of multiple risk and how we have constructed all these different structures that really are gonna make some more vulnerable. Minority children is something that we need to talk about. And so just wanted to point to that as we think about not only mental health, but and the risk of any developmental issue.
I want to ask a question that maybe is hard to ask as it is for you all to answer. Jim, I go back to your presentation and the various reports from the academies about the investments we need to make. And forgive me when I say this, but it's very sort of old style program by program. We need to invest, we need to do more around food. We need to do more around development. We need to do more around income. It sounds very much like a traditional government program agenda. That's how it sounds from the outside. And then, Mayra, you talk about your 3Ds, one of which is defer. And Linda, you talked about the engagement of the population in program design. And I think to myself, how do we change how we think about the interventions that are needed from being these sort of old style programmatic, program by program, defined by some outside government agency, to something that is derived from the wisdom of the community where the experiences are occurring. I don't know how to make this happen, but when I think about the disconnect between what we say works and what we do, I have to feel like part of it is that everyone sees this disconnect and they don't necessarily trust that on either side, that the programs are going to accomplish what we think they will. I'd love to hear thoughts from any of you on how to do that. Mayra, if you have thoughts from the world of advocacy, since you raised the subject of deferring, I'll turn it to you first and then let others join in.
Thanks, Alan. I think it comes down to two things. One is sharing power, and two is accountability. So the first is really thinking about how we authentically share power with communities. How do we integrate them into decision making? How do we ensure we validate their contributions with pay? Debbie referenced the care economy. How do you adequately pay someone for the services that they're providing, whether it's childcare, as she referenced, or in our healthcare system, community health workers that for many times their stipends that they get, they are not integrated as a valid member of the workforce. So really sharing power in our decision-making and our program implementation is a direct way in which we can challenge our system to break down really past practices that have left many, many communities behind. And the second is around accountability. And this is particularly important when it comes to government programs. And how do you build in accountability to track a commitment to equity? It's incredible how the word equity is everywhere now. And people are talking about racism, and people are really stepping up and figuring out ways to challenge themselves and their organizations to do better. But how do we ensure that this isn't a fleeting moment and really build in measures of accountability in ways that, for example, the environmental justice community has done with equity impact, health impact assessments? Can we do the same on equity impact assessments? There are so many organizations across the country that have studied this and have found ways in which we can hold our lawmakers accountable, and we need the political will and leadership to make that happen.
Jim, go ahead.
So, Alan, it's a super question and a great answer from Mayra. I think Debbie laid out one of the major pieces of this earlier on, which is it is time to have clear visibility at the national level about what it means to have a children's agenda and to put it into effect and make it work and get the kind of funding it needs and the political will behind it. That's an important piece of this work. It can't be done by a single venture in HHS or something in the Department of Education or Justice. It's got to be organized, concentrated, politically viable, and politically desired. But it's also, I think, as Mayra was saying a moment ago, it is at the community level that's absolutely critical also to try to integrate these different lines of nutrition, housing, education, health, among others. And Neal has done some incredibly innovative work in this area in a few communities. Others have done some great stuff. I think that's the sort of corollary at the community level where we need to make tremendous progress and bring things together for families.
Linda and then Neal. Linda?
I think going back to Mayra's point around power sharing is really at the root of all of this in terms of who gets to make the decisions. You know, there are so many models out there, I think a lot of times, about participatory budgeting. Like, who gets to decide how the money is spent? How do we prioritize? Because there needs to be a fundamental redistribution of resources, as thinking about, Dolores, the points you make about the communities are fundamentally inequitable living conditions and environments that people are in. And so how do we work with communities to identify those factors and have them think about how that redesign is going to happen, how that reinvestment is going to happen, which is very uncomfortable for folks. I mean, particularly in Black and Brown communities where we're used to regulating everything, we're used to policing everything. And so, but now we have to step back and say the power is yours, the resources are yours, and, you know, we have to be comfortable with the decisions that are made and kind of move back and let communities do the work, but not without the resources. We can't do this if we're not willing to kind of let go of some of that power and resources and turn them over back to communities where the knowledge is. Communities know what they need. We need to sometimes just move out of the way. So,
Neal.
Just to build on some of the other things that people have been saying. We've been working on something now called All Children Thrive, which is an initiative here in California that's at a city level. And part of it represents a real shift in how we do things. One shift is away from focus only on the service systems and the policies that affect service systems, and really focusing on the ecosystem of children's development and health. And the ecosystem isn't oftentimes controlled by the service systems, but it's controlled by cities that control parks and recs and police and budgets and all of that. And it's a different way of bringing service system and ecosystem together and helping cities become micro enterprises of social innovation for children at a local level and begin to move in that direction. There's really great work going on with the All Children Thrive initiative in Cincinnati, being led by Rob Kahn and others there that are really making dramatic changes in what that city is doing. We're launching this in California in 20 cities, and it's really focused on engaging the entire city and creating complex community coalitions that are using different kinds of tools for distributive leadership, new accountability mechanisms, looking at financing differently, and importantly, different kinds of sense making, using data in a different way that brings lots of people into the conversation, tells their story, and a new narrative that it evolves out of it. But it's really a focus not on incremental quality improvement in QI, the way we've been done in healthcare. It's really focused on disruptive transformations that need to take place along the lines that Mayra is talking about, and really sort of focusing on. And there's a whole new tool set that is developed by people that are making complex system changes in areas all over the world that are having to deal with climate change and others. And those tools are available, and they just have to be repurposed into our communities and handed in a democratizing way to families and community members, and get out of their way and watch what they can do with that.
That I was just thinking, Dolores, of your making your data available. So why don't you go ahead and jump in?
Yeah, we are happy for people to reach out and use the data, and we are seeing wonderful uses of the Child Opportunity Index. However, what I wanted to comment on, and I think that people have made wonderful points about the need for disruption and local solutions and innovative solutions. So I'm actually gonna argue that what you call in the beginning traditional programs are also really important. We know that our child poverty rate would be much higher without the AITC, without SNAP, and we know that we could reduce child poverty by half today if we improve those programs in ways that we suggested in that National Academy of Sciences report. However, our traditional programs can also really focus from now on, I hope, in improving equity and thinking more about the outcomes for the most vulnerable children. So let me give two very concrete examples. We have the Section 8 voucher program. And in theory, of course, it helps with housing affordability, and it should also help families move to better neighborhoods. However, because it's operating in the context of this huge residential segregation that we have in our country and the inequities in neighborhood environment that I was talking about, and those are obviously very racialized, not all families that have a Section 8 voucher are going to be able to use it effectively to find a better neighborhood. In fact, we know that Black and Hispanic families are much less likely to find a housing unit in neighborhood with more resources for their children if they have a Section 8 voucher than comparable white families. Another example that we are doing work on right now is that our safety net has holes. No, we know that, we recognize that, but the gaps for children in immigrant families are much worse. We have restrictions for immigrants that affect children in immigrant families that, by the way, are the vast majority of them are U.S. citizens across an entire set of safety net programs. So how can we reconcile a child population that is 25% Hispanic today with restrictions that affect a large fraction of Hispanic families, for example? We need to be much more intentional about equity within our traditional programs, but they are very good in many ways already, and we need to strengthen them.
That's very helpful. I want to get a few more questions in, some of them a little more specific. Katie, there was a question about the multi-generational work raising the topic of grandparents, and that if we're thinking intergenerationally, there's a lot of transmission of health and opportunity that occurs, not just parent to child. I'm sure that just adds another layer of complexity to the analysis, but I wonder if you had any chance to look at that or any response to the questioner.
Yeah, thanks. This is a really interesting topic, and I know that there's some researchers who are starting to delve into this. The unfortunate aspect of looking at kind of those 3 and more generation models is that we typically don't have a lot of data to really delve into it too deeply. There's a couple of data sets that will have 3 generations. PSID is the one that I'm thinking of off the top of my head. But anytime that you start looking at those more and more generations, you're going to be cutting your sample size a lot. And I think a lot of the issues that we've raised today focus on the important disparities that we see by race, ethnicity, by income, by these other demographic characteristics. And then anytime that you want to look at what's really happening then in that 3 generation type of model, you're going to be looking at a smaller and smaller sample size. So I think at this point in time, there are some big data limitations to that, but absolutely a big question.
Thank you. There were 2 questions that are fairly different, but I'm going to combine them. One having to do with the diversity of clinicians, particularly in this instance, a pediatric specialty, but also a question about the role of safety net providers and their presence in various communities. So I'm thinking, particularly for those of you whose work was geographically focused, whether you have a sense within the work you do of the availability of healthcare providers and anything about the characteristics of those providers. And to those of you whose work isn't directly on that, just if you have additional thoughts on this topic.
One thing that I would say is I think that was something that kind of surprised us with our results, is that we really didn't see a whole lot of differences in terms of health mobility for children by rural versus urban versus suburban areas. And I think that was something that kind of surprised me. We'll have to keep looking at it going forward, but yeah, I was kind of expecting to see some more differences than what we actually saw.
Other reactions? Well, we're just about out of time. I want to close. It's a big question, so I'll ask for brief responses. I'm particularly thinking about the different tools that we come away with, community level resources, children's development, intergenerational mobility, all very different concepts and constructs using different data, all telling some of the same story, although the nuance is quite different. So the closing question is, how do we take advantage of the differences across these ways of thinking about prospects for children's success to weave together the story that's needed to advance the field? Because we have this richness that I would hate for us to lose. Any final thoughts on this? If none of the researchers do, Mayra, I don't want to put you on the spot to close, but I always say that and then I do it. I tell you what, Jim's raising his hand. We'll let Jim get a word in, and then Mayra will let you close us out for this session. Jim.
There are some common themes, Alan. I really think that they are, involving people in their own lives is absolutely critical at all levels. I think that really combining intersectoral stuff is really critical. I think addressing inequities directly and not simply labeling it as old-fashioned disparities is absolutely critical. And I think building a national agenda is absolutely critical.
Mayra?
So I completely agree with what Jim said, and I will only add two thoughts. So one is Debbie referenced earlier, really looking at the political leadership that we need. One idea is to create a national office on children that prioritizes cross-sector initiatives and work across the federal government in order to ensure that health is speaking to early childhood and education and housing, given that it's multiple challenges that families are facing. Families don't have the luxury of living single issue lives, neither should our programs, and really thinking that through. And then finally, this work is hard. And just as healthcare is personal, the journey to become anti-racist is personal. And it requires learning, ongoing learning in that journey for all of us. And I think our personal commitment to that will also be reflected in our organizational and governmental work.
Okay, well, I want to thank our theme advisors, Chris Forrest and Lisa Simpson. I want to thank the foundations that and organizations that made this issue possible. Nemours, Blue Shield of California Foundation, the Children's Hospital Association, the Episcopal Health Foundation, and the W.K. Kellogg Foundation. Most of all today, I want to thank our presenters, terrific research that we're really proud to publish in Health Affairs and presented beautifully today. And Mayra, for your perspective on this from the real world and on the ground in the world of advocacy. It's a great privilege for us at Health Affairs to be able to host content as excellent as this. And with that, and our sincere thanks, we are adjourned for the day.